Good morning. Part of patient safety is an effective tracing of many areas. Today we're going to talk about how we trace a procedural area. One of the first things we look at when we walk into a procedural area is the physical environment. We look for several things within the room, paying no attention really to the staff that are there at this point. We want to make sure that, and we try to get there before there's a patient in the room so it's not disruptive to the patient activity. So we've listed here for you the items that we're going to look at. The important thing is that everything is clean and orderly. There's no dust hanging or present on any of the high equipment in the room. The walls are in order, nice and smooth, with some kind of paint on them or tile or board. The floors are clean with no divots or gouges in the floor and no broken seams that haven't been repaired. We also, when we're looking at the room, we want to make sure there's no rust on any of the equipment that touches the floor. Frequently we see rust around wheel wells or up the legs of equipment due to the fact that we clean that room so frequently and it automatically splashes some of the cleaning fluid up on the equipment. So we want to make sure that that's gone too. We want to look at the anesthesia prep area before they actually start the procedure to make sure that we're using single-dose vials. And if using those single-dose vials, and if some of the items are already prepared, are they in syringes that are labeled? And if necessary, are those syringes timed? Specifically, we look at propofol. And the timing of the expiration of propofol is 6 to 12 hours, depending on what your organization requires. And that timing has to be marked. And that's from the time the vial is punctured, and the 6 hours begins at that point in time. Laryngoscope blades have been a hot topic for several months now. We want to make sure that laryngoscope blades are in their original packaging and not laying just open in a drawer, or that they are set up and ready for use, the blade that they plan to use, on the top of the anesthesia table, but covered with a blue cloth or whatever type of cloth you use in your organization. We want to make sure when we walk in that there is an attendant, usually the scrub tech, is near the scrub table. Once the table is set up, you cannot cover it, and we occasionally in procedural areas, not in the OR, see that people cover that table so that they can do other activities outside the room. Once that table is set up, it cannot be covered. Covering the table, when you remove the cover, flips dust and debris into the air, and we stopped doing that years ago, but we still occasionally see that. We also want to make sure that the attendant remains in the room to protect the table, essentially, and make sure that everything on it remains sterile. Another issue that has more and more come up in the last year or so is surgical attire. We look at how the staff that are working in the area are dressed. And in procedure areas, staff have a tendency to be a little more lax than they do in an OR. So we want to make sure that all facial hair is covered. You can see the picture on the right that shows a gentleman with facial hair who has a full hooded mask on, and underneath that he also has, you can see a little corner of it, the blue cover cap as well. The person on the left still has hair showing. If you're over the surgical table or over the patient, then you must have all hair covered. We want to make sure no visible personal clothing is present. So you can wear a t-shirt, undershirt underneath your scrubs, but you can't have long arms or a neckline showing out. So we want to make sure that those things are in place. Once we've entered, we also want to make sure, once the patient is entered, we want to make sure that the hair clipping was done in the preoperative area, if there is hair clipping, and not in the operating room. It's almost impossible to mop up hair in an operating room. You actually have to vacuum it. Not many people vacuum out their hair and vacuum an operating room. So we want to make sure that we're following guidelines set up by CDC, APIC, and other areas that say if you need to clip hair, which is clearly controversial. There are many studies that say you don't even need to clip hair, that it does not increase the risk of infection by leaving the hair in place. But if you are clipping, it's done prior to the patient arriving in the OR room. Timeout still, we struggle with that a little bit in healthcare. Everyone uses two identifiers very well. Whatever the two identifiers are in your organization, you want to use those. All members have to pause for their activities during the timeout. So what is probably the best way to do it is say, is everyone ready for the timeout? And if you get verbal acknowledgement, then everyone is ready. Then you can begin the timeout. But that also gives the team to say, time to say, okay, no, wait a minute, just give me a second here. I want to finish giving this medication or positioning my equipment. And then once everyone is ready, you begin the timeout, everyone pauses, and at the end of the timeout, everyone verbally acknowledges the information that was presented. It's important that we verbally acknowledge it. The documentation of the timeout is only that it was conducted. That's the only requirement. However, if your organization has a policy that requires more, you want to include whatever in that documentation, whatever the organization requires. Once the procedure starts, there should be limited access to the room. Entering through the central core rather than through a common hallway is the best way to handle that. So our successful solutions to procedural activities is number one, linking the teams. The AORN states in their website, on their website and in much of their literature, that they set the standards for all procedural areas besides the operating room. So those include, just to mention a few, you can see in the diagram here, interventional radiology, L&D, cath lab, and endo. We want to maintain our mindfulness that these folks need to all be coordinated and following the same rules as an operating room. And so link your teams together. Send a representative from L&D or endo to the operating room monthly meeting. And get together and look at each other's procedural areas and look at what the OR is doing. Trace those areas that aren't your own so that you become familiar with what's going on in all those areas. And of course, everything we do, AORN, APIC, everything we do is based on evidence that is current. Hope you have a good day, and thanks for stopping by.